Dr. Rivera is a cardiologist who was trained in Mexico. We adopted him into our family of cardiac rehabilitation 4 years ago. He initially completed his fellowship in the cardiac rehabilitation, and now he is in the clinical fellowship with the TGH, learning further and sub-specializing further. And he's also involved with research, and his research focus is on cancer rehab as well as heart amyloidosis. It's my pleasure to have Dr. Rivera talk to us today about cardiac toxicity. And he's a great speaker and a very talented teacher. So enjoy his presentation. I will just let you guys know that we will have about 30 minutes of his presentation, and then there will be a Q&A. During the Q&A, floor questions as well as online people can put on in the chat, and he will be answering those questions. If any of the questions are unanswered due to lack of time, Dr. Rivera is more than happy to continue answering them through his contact, and he will let you know how to contact him. So enjoy.
So thank you so much for that kind introduction, Dr. Nijawan. I want to also thank the amazing team that is behind all these presentations. For me, it's truly an honor to be in front of you, to tell you about what I do, about my passion. And just remember that everything that we do it for you, right? This research that we are doing to improve the health of all patients that have cancer or they're struggling with this issue. So that's our main goal. So my presentation today is going to be the intersection of two fields, that is breast cancer and cardiovascular disease. And I'm going to tell you a little bit more of how these both conditions relate and how we can improve our health from different perspectives. So we're going to have some goals for today. First is to recognize the impact of the cancer treatments in our cardiac health, as well as establishing how important it is to collaborate between different fields and specialties to improve the health of the patients. And we're going to discuss some of what strategies can we follow to improve your health. First is we know that cancer is one of the biggest problems in Canada, is the main cause of mortality among adults, followed by cardiovascular disease. We're going to share that in women, cardiovascular disease is the main cause of death. Also, we know that Canada is one of the countries with the highest incidence of cancer as well. And that is related to the health habits that we have, the diet, the lack of physical activity. But as well, we know that 1 in 12 Canadians are living with heart disease. So there is a high prevalence of both conditions in Canadian adults. And as we know, also 2 in 5 Canadians are expected to develop cancer during their lifetime. So this is why this is so important to start talking about. Talking about breast cancer is the second cause of cancer in Canada. 1 in 8 women will develop cancer during their lifetime. And as we said, in women, breast cancer is the main cause of comorbidities, as well a part of cardiovascular disease. And above 80% of these cases happen in women aged above 50 years. However, there's good news as well. Now, with all the improved strategies to diagnose this problem and to treat it, we know that 82% will be diagnosed at an early stage, and that will impact the survival. And we know that now, in Canada at least, we have a survival above 85% at 5 years. And this is great. These are great news. And we are above the mean in the world for this. So we know that this is going to persist You had cancer, but you will have that diagnosis and the therapies and those side effects across your life. So we need to understand having cancer will relate to other problems. And we know that the people that had cancer before are at a higher risk of develop cardiovascular disease. And now the cardiovascular disease is becoming the main cause of death related to cancer diagnosis. So we're going to try to talk a little bit about this relationship. Some statistics, we know that after being diagnosed with breast cancer, there's increased risk of heart attacks and stroke. As well, as we mentioned, cardiovascular disease is the main cause of mortality in women. As well, 87% of women with breast cancer have at least 2 cardiovascular risk factors. And we're talking about hypertension, obesity, high consumption of alcohol, etc. And in postmenopausal women with a hormone receptive positive breast cancer, as you have been, maybe you know about this, when we give specific therapies, cardiovascular deaths exceed the cancer mortality. So we have amazing therapies, as you know, with Herceptin or pertuzumab. They target the cancer and they are great for that, but they carry some side effects that are going to affect the heart. And this is what we have been discussing today. In this chart, you can see that how is it the years after the diagnosis of cancer, and in the y-axis you can see the percent of mortality. So at the beginning, the mortality of breast cancer is slower, is going to keep decreasing, but the mortality of cardiovascular disease is going to increase across the years. And we're seeing that now, after some years of the diagnosis, these lines intersect, and then we can see that the cardiovascular disease is becoming of a major issue. And why is that? We have shared risk factors. We know the traditional risk factor for cardiovascular disease: hypertension, dyslipidemia, inflammation, prior history of heart disease in the family, other specific factors that affect the woman, such as preeclampsia, pregnancy associated hypertension, depression, anxiety, diabetes, immunological disease as rheumatoid arthritis. And in the other side, we have the risk factors for breast cancer. We have genetic factors, also some kind of radiation to the chest, late or no pregnancy, the use of contraception pills. But there are factors that are related to both conditions, such as the age, the diet, that is a diet that is high in saturated fats, in sugars, the consumption of alcohol, being overweight, not doing exercise, smoking. All these factors impact both conditions. And that's where we start to understand how these both conditions relate. And did you know that 1/3 of the cancer deaths are related to the use of tobacco? Having a high body mass index that is related to increased weight related to your height. Also, the consumption of alcohol, not taking enough fruits and vegetables, and not doing exercise, which is a huge number. And we can see that from there, we can start to understand how we can prevent these deaths at a very early stage. So now I'm going to talk a little bit about the direct injury of the cancer therapies to the heart. As you have experienced before, when you're going to start treatment, they tell you about some of the side effects of possible harms that you can have from these therapies. So one of the traditional regimens includes anthracyclines that you know, the doxorubicin, as usually was told in the past as the Red Devil. I don't like the name, it sounds horrible, but it was called like that because it was very harmful as well. And the specific therapies that are related, for example, having hormonal receptors as the trastuzumab, that is called the Herceptin. These both, and all these therapies can be related to conduction abnormalities in the heart, like arrhythmias, even the radiation, pericardial disease, that the pericardium is the little layer that protects the heart, and this can get swollen and have inflammation due to the therapies. We can have myocarditis, that is the acute inflammation of the heart. There's new immunotherapy that we are using for breast cancer now, and now we are seeing that we are having side effects to the heart immediately after starting the therapies. So we need to think before actually giving these therapies, how we can prevent these problems. Cardiomyopathies, and this is one of the biggest problems. We call cardiac dysfunction, and it was previously called cardiotoxicity. That is the direct damage of anthracycline or trastuzumab to the heart, having the risk of produce heart failure. And also some valvular issues that could be related to the radiation. In the other side, the radiotherapy can also produce problems into the heart, like coronary artery disease, the dysfunction of the valves of the heart, microvascular disease, not only the big arteries, but the small artery of the heart, conduction abnormalities, producing a scarring about in the heart and around the heart, and the inflammation of this little layer that covers the heart. But not everything is bad news. We know that now the technology is allowing us to create better strategies to protect the heart when people is receiving radiotherapy. So with these new techniques, what we are avoiding, as you can see in the image, is the radiation is targeting the breast, but it's basically not touching the heart. So these new techniques that they are developing are focused to protect these complications from the future. As well, the next question will be, who is at high risk of developing these heart issues related to therapies? First, when we have higher doses of radiation involving the heart, when we have higher doses of anthracyclines. A usual treatment of anthracycline includes 240 milligrams per square meters of doxorubicin. So in some patients, they need more. So the more that we give, more the risk is going to be, and we need to be more careful to give better surveillance on this. Also, having an older age at the time of treatment. And also, the more risk factors that we have before treatment is when we can have more problems related to the heart. So if we think that before even receiving treatment, somebody is healthy, is eating well, is doing exercise, we can be sure that there's going to be good effects to protect the heart, even before receiving the treatment. And also when we combine therapies, because we need them, and we know that these therapies are going to protect the patient and save the life from the cancer itself, but we are understanding that in the long term, these ones could affect the heart. So we are going to be working to try to create strategies related to this. Now, from the cardiology perspective, what do we do in the clinic, in the cardio-oncology clinic? Our goal in the cardio-oncology clinic is to screen and to prevent these problems. And when the problems happen, to treat them. So what tests can we use to screen for these issues? There are many tests. So many of you maybe did a Muga scan. They take some images and pictures of your heart, and then it gives us numbers as the ejection fraction that I'm going to talk a little bit more about. And most traditionally, and one of the most common studies that I will share more information is the echocardiogram. But we have also the electrocardiogram, stress tests, nuclear tests, cardiac CTs, MRIs, and all this is in our battery of studies that we can use for specific conditions. But the most common one for screening is the echo. And what is the echocardiogram? The echo is an ultrasound that is going to be taking pictures of your heart from different angles. But not only to take pictures, it's also going to give us information about the function of the heart. How are the pressures? How are the valves? How the heart is working in your body. And this study doesn't use radiation at all, doesn't hurt, and it's pretty fast. It takes like around 30 minutes, and the only thing that you are asked is to lay down, to breathe normally, and not be worried at that moment. And as you can see in the images, we use a little bit of imagination here, and that's why I put an image with the correlation with the real heart and with the images. So when we see these echoes, we analyze every picture of your heart and to see how it is moving. And then when we take studies throughout time, we can compare your first study versus the next one. And that's when we can identify very subtle changes in the function of the heart. As I mentioned, what we measure and two terms that you will be hearing a lot is the ejection fraction and the strain. And this will help to analyze the function and the structure of the heart. So first, I'm going to talk about the ejection fraction. What is that? So the ejection fraction is the fraction of blood that is pumped out of the body with every heartbeat. So it's just the amount of blood that the heart is squeezing in every beat. The normal ejection fraction in general is about 50%. And that's what we want to see. We take the initial echo before you start those treatments, and we follow you with that. And we can start detecting if there are abnormalities. However, the ejection fraction, when it's reduced, is because there's already damage. For that reason, it has been a study, and here in our center also, we are pioneers in working with the strain. And we are pioneers in the world to identify that the strain can identify very early changes in the function of the heart, even before the ejection fraction drops. And the strain is how the heart squeezes itself. So we take a lot of different pictures, and then we measure every little part of the heart of how it is beating and how it is squeezing itself. Normally, the values are in the negative. So -18 is good, -19 is good, -20 is good. When they start dropping before and become more negative, it has to be that the heart is not squeezing as much. Like when they're going to -17, -16, -40, that's abnormal. Now, what is the relationship of the fitness capacity? We are in a rehab program, and what we want is to promote exercise. So why is that reason? And just remember that exercise can improve your mood, and it will be very hard to feel blue when your cheeks are pink. So the fitness capacity. The fitness capacity is a strong predictor of health. When you did your stress tests, we measure the VO2. That's why we were using this mouthpiece, and this has shown to predict health in the future, and is related to health in patients that had cancer. Also, having a good fitness can reduce the mortality of any cause by over 50%. And we're talking about stroke, we're talking about cancer and cardiovascular disease. Also, we know that just increasing by a little bit the fitness capacity will be associated with reducing the risk of cardiac events, like, again, heart attacks, stroke, and other events. So just every effort that you are putting every day in your exercise is giving you benefit. So how is the fitness capacity affected by the cancer therapies? So the fitness capacity is not only your heart, it's the relationship between your breathing with your heart and all the muscles of your body. So the surgery, the chemotherapy, and other therapies will affect the function of your lungs, the function of your heart, how the oxygen is delivered to the body, and as well, how your muscles are utilizing that oxygen. So for that reason, exercise can target all these different aspects that are complications from the cancer therapies. But what about other things? We already talked about the cancer therapies itself. There are other problems that are related to this. There are other side effects like brain fog, the neuropathy, the poor coordination, anemia, pulmonary issues, the hormonal deficiencies that we can have from therapies, loss of appetite, sensitivity problems in the skin, osteoporosis. And all these problems will produce other issues like cognitive, physical impairment, increase of weight, and also increase the risk of having more heart complications. So from one side, we have the direct effects of the therapies in the heart and in the cardiovascular system. And then we have all these conditions that all will further impact your health. So what do we know and what we can do for you? First, in this visit table, I just want to tell you, this is what we see in cardio-oncology. When the diagnosis of cancer is being made, now we know that we need to think in the cardiovascular system. So we do an assessment to evaluate the risk factors, understand where is the patient at that moment, and we create categories between low risk, medium risk, and high risk. And depending on how we categorize the patients in between these risks is what the actions that we are going to take, like give you the standard surveillance, or referring you to a cardiologist or to our cardio-oncology department. They start giving you treatments, controlling your risk factors. As well, based on this strategy, when we divide by risk, we have a lot of different standardized procedures that we will take to protect your health. And this table is just a little example of what we do, for example, with the use of echocardiogram, cardiac biomarkers, and other studies that we will take during your therapies with anthracycline or trastuzumab. So when you're seeing your doctor, we're all thinking all these things in the background. Sometimes seems very easy, but there's a huge research behind all this to support that the decisions that we are taking are focused to improve health. As well, as I was mentioning, so when the diagnosis of cancer is being made, we think in this cardiac assessment. If there's problems like already established with hypertension, with heart failure, we start treating at an early stage to avoid reducing delays in the cancer therapies, which is our main goal in cardio-oncology. It's not delaying the therapies related to cancer. But that's from a one perspective. Now we start to think and understand that we can do more. And that is with cardio-oncology rehabilitation. We know that cardiac rehab can help controlling the risk factors and also modifying good behaviors. So for that reason, we start developing this new program that we are pioneers here in Toronto Rehab, across Canada and across the world. So we want to start breaking paradigms. We want to start thinking big. So we start creating the connection between two fields of medicine. One, a novel field that is cardio-oncology, that the goal is to allow the patients to receive their therapies in a safe way, minimizing all side effects that are related to the cardiovascular health. And in the other side, we have cardiac rehab. That is a proven intervention that can improve your health, your quality of life, your fitness capacity, and some of the behaviors to prevent problems. So a lot of people around the world got together and start thinking how we can start delivering this and how we can start making knowledge and awareness, not only for patients, but all doctors and hospitals, that this has a role to play and we can prevent issues. So recently, different societies in medicine, the European Society of Cardiology, the American Heart Association, and the International Cardio-Oncology Society start supporting these programs. And we have these programs is not related to one specialist. It's not cardio-oncology. We're working with oncologists. We're working with kinesiologists. We're working with physiologists, with researchers, in order to bring all those benefits to you. So this team approach is designed for your needs, and it has to be always very individualized, thinking in the unique needs of every patient. And all your care team is going to be working together for you to minimize and control this. Every patient is different, and we understand that, and that's how we want to tailor an intervention that is designed for you. So when we're talking about this new role of cardio-oncology rehabilitation, where can we implement it? First, there is a term that we call primordial prevention. That is, even before the cancer diagnosis is made, just managing the risk factor and the comorbidities of patients that will not only prevent cancer, they can also prevent other problems. But once that we start treatments, we have primary prevention. So allowing patients to receive their chemotherapies in a safe way, and also minimizing the risk factors as the cancer-related fatigue, the brain fog, and the reduced fitness. And a secondary prevention strategy, once that somebody has problems, if they're having a lot of fatigue, if the fitness capacity is low, we can also start using these programs to improve their health. So with all that I'm saying, we talk about the risk factors. We talk about the direct injury of therapies and this indirect injury from the side effects of the therapies and also these added conditions related to the cancer diagnosis and to the therapies. All these will increase the risk of having cardiovascular disease, the frailty, and will increase the morbidity and mortality. But we don't want that. And so we know that we have a strategy that also is multiple hit, can target different things. And that's exercise. We can improve the quality of life. We can improve the fatigue. We can reduce the risk factors that we talk, and we can improve your fitness. So now we are going to talk, what steps can you take to improve your health? First, being aware of your health. Being aware that you need to take charge of your own decisions to improve your nutrition, to reduce the alcohol consumption, and also talk about your health with your team. If you have concerns, talk about them. Make time to take the right decisions for your health and take an role to control all these risk factors that we're taking. If you have diabetes, if you have hypertension, take your blood pressure. If you are concerned about these numbers, talk to your care team. Second, physical activity. We know that at least 150 minutes of moderate physical activity a week will give you positive benefits. And if you are not sure what kind of physical activity you can do, start walking. If you're walking 30 minutes a day to a pace that you feel comfortable, that's an excellent. It's a great way to start. And talk to your care team about it, how you're in the best place here where we can give you all these recommendations. Because we know that being inactive is related to an increased risk of heart disease. Nutrition. During the week, we have also a very nice talk from Dr. Hernandez that she shared what kind of nutrition we can follow. Taking smart decisions when you're picking your food is very important. We have different diets, like the Mediterranean diet. Eat as natural as possible. Try to eat less processed food. Trying to think, how much energy are you using versus the amount of energy that you're consuming? Food is energy, right? So we need to try to balance these things. If we are eating a lot, but we are not consuming energy, even if we are eating healthy, it's not that good. So we need to think in that as well. And limiting some foods that are high in saturated fats, cholesterol, salt, and alcohol. And as I said, always, it's not just being prohibitive, but just try to pick natural foods, less processed, that are not coming in a box. And fourth, stop smoking. I think with this message, we have enough information that there's no reason to smoke. All smoking is bad and it will harm your lungs and will harm your heart. And same with vaping. Now younger generations are switching from the cigarettes to vape. And we know that vaping has even worse complications than smoking. So, and if you are smoking, if you want to change that, search with your care team. What options are available in your community? We have amazing programs that are available, that are free and will be accessible for you. And fourth, try to control your weight. We don't have a specific target. It's like you need to reduce these, but just try to think in these things, how you're expending your calories and how you're taking your calories. So part of the key takeaways for today is that you need to take the right health choices and prevent disease and all the key complications, and be an advocate for your own health. We'll be there for support you, but you need to be the one pushing your doctors, pushing your team to help you through this problem. If you have questions, ask. So in conclusion, I want us to talk. So we need to think as healthcare providers to innovate. What strategies can we adapt, create to give better outcomes to our patients? We need to base our decisions in research. If I'm giving a recommendation as a health provider, it's because it's proven to help you. It's not what I think, it's what the evidence has shown us. And that's why it's very important to get involved in these initiatives. And patients as well, you help us when you participate in our research projects because you're helping other people as well. We need to have hope because there is hope to improve. And that's something that we always want to share, that if you're not feeling well, there are ways that we can take to improve. Self-management. You need to advocate for your own health. You need to understand what you need to do. We are going to be giving you a 20% and the rest of the 80% is on you. Effort. All these things are not easy. It takes a lot of work to eat well, to do exercise, to find motivation. But this is going to impact in your health. Find support. We as health providers are here for you. And having these groups is one of the best things that people can have because you can support each other. Just think that the person next to you is having the same struggles as you, and collaborate. And this is for us as health providers, with our communities, with our patients. All health providers need to be involved in your care. And prevention is the best known strategy to improve cardiac and cancer outcomes. Now, as we were talking about research, we're doing a research study to prevent. And we're trying to find first-degree relatives of people who have cancer. If you have relatives that might be at risk of having cancer in the future, and they're not eating well, they're inactive, we have a virtual program that is free and it has coaching in health, is part of our TRI group and has a peer support group. It has exercise, nutrition education, and it will be personalized for your health profile. The goal is to improve the health of people at risk of having cancer. If you're interested in this, please don't hesitate to ask for our team. Our collaborator Becky is here at the back. So also feel free to reach. We are going to give you some flyer. And as well, I want to share some other resources from our amazing health program and health team. Feel free to reach to them. They're amazing. Promote these for people that you know that might be struggling. Having these kind of programs, we're privileged to have it because in other parts of the world, they don't have this kind of initiatives. Also, if you're strong with cardiovascular disease and you had a history of cancer or you have cancer, we have our cardiotoxicity and prevention program that is one of the leading programs in Canada. Also, we have our online services with Health University, where you can access a lot of information of how to improve your health, your nutrition. And also we have the Elixir program at Princess Margaret that is more related to physiotherapy, to improve different specific problems related to the cancer diagnosis and to the therapies. So I want to thank you for allowing us to be with you today, to listen to us, to the whole team, to Dr. Kolela, Dr. Cody, Dr. Nijawan, that have been leaders in promoting this initiative. And we want you to stay involved, stay in touch with us. We will have more initiatives that you can participate. We will keep promoting this and we'll be keep working very hard to promote the health in our patients with breast cancer. Thank you. Now, if anyone has any questions, we're going to be opening the session for Q&As. Please let us know if there's anything. Feel free to write in the chat. Feel free to ask. So this time is for you now. Yeah. So the question is how we can approach our healthcare providers to improve the awareness and how we can approach our communities. So first, I think that from the healthcare providers, we're working very hard to work with the oncologists. We're trying, but we need to build capacity as well, right? We cannot have everybody in one program, but we need to start creating little programs across our province, across Canada. And we're doing that slowly because it takes time. We're starting to work with the radiation oncologists. We are trying to reach the surgeons. In our program, how we collaborate with in cardio-oncology is direct with every physician. So if your doctor has concerns about your health, they let us know directly and we get them to know directly what are our thoughts so we can plan the therapies together. So this approach of collaborated medicine is one of the answers for that. And in the other hand, we have the community, and that's a little bit harder. And I think education will solve a lot of the problems of our society, right? But we need to start creating noise. We need to create campaigns, not only for people that already had the problem, and that's where prevention and our program goes by. The initiatives that we have with the acceleration program is exactly that. It's people that might be at risk to start to get to know that health is important, that it will be related to your life in the next 10, 20, 30 years. So from our end, we can start doing that. And we are trying to create initiatives to work with the communities. We need to do better because I think we are still lagging a little bit behind with that, but we are going to keep trying, at least in our organization at UHN and with other hospitals, we are starting to push this, but this is a new field. So we are going into that direction. In the other hand, with the International Cardio-Oncology Society, we have a new initiative to give every patient that has a cancer diagnosis a pamphlet, a flyer of how to exercise. So we are in work with that, and we're working with Australia, we're working with many countries to create a standard that every patient that goes with an oncologist receives some recommendation for primary prevention. So we're starting the process to build this. Any question? I have a question from the chat. I'm going to read the first one. And what is recommended to have a holistic approach to heart health? Work with your family doc to coordinate some of the more medical and upside to life. So I think heart health monitor with an ACG. So I think with that, the holistic approach, I think, is very important. And this is what we are talking. So if you're seeing your family doctor, your GP, talk about your health. Ask what programs are available in our community. And maybe not all of them they will know, but they will know to refer you to the right place. And I will pass to the next question. Is it a standard best practice to test and check heart during cycles of doxorubicin? Because my late husband oncologist didn't do any checks whatsoever except for the initial baseline, and he ended up dying from heart failure. So this is a little bit, I'm sorry to hear this, it's a little bit hard to hear, but we're doing better. And I think that's what we want to do better. In the past, we didn't know that all these problems were related to the heart. We're starting to understand because now the survival that is increasing, we are seeing the overlap of problems with the heart. So we are going to work hard to keep promoting all oncologists to work directly with their cardiologists. Any more questions here in the, yeah? Yeah, that's a great question. And thank you for asking because I didn't put a lot of attention into that. These hormonal therapies, sorry, the question in the room was if the hormonal therapies are related to heart issues. And the answer is not directly. It's not that by you taking it is going to affect your heart. However, we know that hormonal therapies could be related to increase other risk factors, like the blood pressure, the cholesterol. So rather that it's not going to affect directly, we need to be aware of managing the cholesterol, managing the blood pressure, managing your glucose, or at least being followed by your family doctor with these parameters in a yearly basis. You don't need to be checking that with echoes because it's not going to affect directly the heart, but it's like that part of prevention. Before any problem happens, just keep everything under control, do your exercise, and that will help a lot to tolerate the treatment and to avoid the side effects that are related to the cardiovascular system. Yes. Your question, and the question is, if all these efforts and information was shared with the therapies, side effects are related only to breast cancer or to other cancers as well? And the answer is related to other cancers as well. Today was focused more in breast cancer as we are doing our campaign with women heart. But the reason is, yeah, depending. The use of anthracyclines, for example, is used in hematological cancers as well. Treated lymphomas, leukemias are treated with anthracyclines as well. Immunotherapies that are also can affect the heart are used for colon cancer, lung cancer, renal cancer, so skin cancer with melanoma. So these issues, and what we work in the cardio-oncology program is with all kinds of cancers. And it's not only the use of anthracyclines. We are now starting with new medications. They are not chemotherapies, but are immunotherapies. They target the immune system, but the immune system can respond in a bad way and produce inflammation in the heart. So we're seeing it. Problems with radiation in lung cancer to the heart. So what we know is that all these benefits of preventing disease with exercise, with a good diet, will impact the health of everyone, not only patients with breast cancer, but all kinds of cancers are related. So these benefits, and that's where we are trying to work. It's not only having our health program. We want to have a prostate cancer program. We want to have a colon cancer program for rehab as well, because there are other populations that we are not seeing. It's not the topic of today, but prostate cancer, men with prostate cancer, they don't die for prostate cancer, they die for cardiovascular disease. So we need to start thinking how to approach every single group to share these benefits. No? Okay. So the question that we receive in the audience, thank you so much, is about if we know that cancer therapies could be related to heart disease. Now the question is, heart disease is related to cancer? The answer is not directly, but we know that the risk factors that for cardiovascular disease, such as obesity, smoking, and an abnormal diet, they do increase the risk of having cancer. There's some observational studies, and there was one that it was done in the US, which included hundreds of thousands of participants. And what they saw is that people that had more heart issues have more events of cancer in the future. However, we don't have a causation, it's a relationship. So we know that they have more, but we don't know why. Maybe, but and it is thought that it's not that the heart is giving you cancer, but the risk factors and the people that is having heart disease smoke more, they drink more, and they have an abnormal diets, and that's why they have increased risk for cancer. I don't know if that.
Yeah, that's perfect.
Perfect. Any other question in the audience? Yeah, please. The question is if why Canada has a high incidence of cancer. So, which is it's a very good question because we don't know exactly the reason because we cannot give causation, but we know that as a country with more resources, the type of diet of people is different than in developing countries, and also that is diagnosed more. The statistics in Canada are better than in other countries, but we know that the incidence is higher. The people don't die more from cancer in Canada than in other countries, but they are diagnosed more. So there are different factors that are involved, and also the lifestyle is very important, and that the lifestyle I will give more attention to that. So I'm going to repeat the question is the relationship between, I'm going to summarize your question, Christine, the relation between consumption of alcohol and cancer. And yes, one of the main risk factors of not only breast cancer, but a lot of different cancers is the alcohol consumption. And I think we're starting to understand more and more about this relationship that is related to the inflammation that the excessive alcohol consumption carries. So yes, it's related. Consuming a lot of alcohol is related to higher incidence of breast cancer, colon cancer in specific as well, and other cancers like prostate cancer as well. And it's not something not directly, but the metabolic changes that the excess of alcohol produces in the body. And this is similar, for example, with the amount of food. There are few foods we cannot say that food is related that is going to give you cancer, but it's what changes this type of food produced in your body that will produce an environment that is abnormal, that will produce inflammation. And that's what is related. The amount of chronic inflammation that could be related with the excessive alcohol intake. So recommended now is the less alcohol, the better. Thank you. Okay, we have a very good question from the audience that the increased risk of breast cancer in estrogen is estrogen related. So this is a very good question, and it's related. There has many answers depending of what perspective we take. We know that there are breast cancer related to excessive amount of estrogens, but however, this relationship is not always linear, and it depends. There has to be a predisposition in the patient to have breast cancer. It's not only because all women have estrogens and not all women develop cancer, but when this excess of estrogens could be related to cancer. So there has to be certain predisposition. And that is part of the risk factors with the use of contraceptives based on estrogens and breast cancer. So it is thought, and it has been seen, that patients that take estrogen-based contraceptives, because we know that our progestin, that all different types of contraceptives that are related, but the cancer itself can have receptors for estrogen. So that's why in certain types of cancer, we block the estrogens to avoid having this risk. So yes, there is a relationship, but we need to be careful how we frame this relationship, because it's not that estrogens give you cancer, but estrogens can be related to the progression of a cancer as well.
Does it increase your cardiac risk if your cancer is estrogen?
Okay, the question is if we have increased heart risk if we have an estrogen receptors for the cancer. So not really. So we know that when we have a cancer that has receptors for estrogens, if we block the receptors, it's better, and we can control the cancer. So it doesn't give a specific cardiovascular risk. When we have more worries is when we need to give therapies that are related to this. And the triple negative, for example, cancer, that it has no receptors for progesterone or for estrogens, that carries also more risk for cardiovascular disease. So this relationship is not fully understood at this moment, but we need to just be careful with those things when we know it's more related to the treatment itself, but not to the heart. Thank you, Lisa. I'm going to rephrase your question is, what kind of cardiac conditions are related, are increased with cancer? And mainly what the observational studies, there was a study that was published this year in Alberta that analyzed 4 million people, and they saw people that had cancer and then what kind of cardiovascular problems they had. And what they found is that mainly heart failure, and then thromboembolic problems, pulmonary embolism, arrhythmias, and other conditions. SCAT is not related at this moment, but other conditions could be related, but mostly heart failure. The reason is heart failure is related to the use of therapies that we saw, anthracyclines, trastuzumab, and other ones. And the other one, pulmonary embolisms, also different cancers increase the risk of creating thrombus, to creating clots in the lungs. So that is where the relationship is, and it's part of this of the inflammatory response of the cancer that can produce it. Thank you for sharing your experience. I'm going to rephrase it for our audience that is online. Is that letrozole causes palpitations, and after letrozole was stopped, the palpitations stopped, and tamoxifen was started, and there was no issue. And the question is if letrozole can have long-term side effects to the heart, and I don't think no. I will say no. No long-term side effects, nothing that you will need to be concerned. However, we don't know, I don't know why exactly you had those palpitations, if there was anything else related, but I will say just be careful. If you are having palpitations, again, let know your cardiologist. I will not expect any problem, long-term problems from the letrozole, as the normal things that we are discussing, managing all the risk factors. So thank you for sharing your personal experience as well. And so I'm going to rephrase your question and your concerns that you present in cardiovascular disease. You have coronary artery bypass years after having breast cancer. And the question is if this was related. So we see that what you mentioned in the graph, the mortality intersect between cancer and cardiovascular disease at 8 years. But what we have seen is that the period where we are more susceptible to heart damage is in the first 2 years when we start therapies. Those moments are key because, and even for us, if we detect the damage at a very early stage, then it will prevent problems for the future. So, and that's why we're now creating these strategies for screening patients. Because in the past, as it was shared from one of our participants, they took an echo at the beginning and then they forgot about the heart. And then the problem is if the heart issues start right when with the chemotherapies and the patient continue with chemotherapies, then in order to recover the function of the heart is going to be very hard. So if we are start screening at a very early stage and we detect any abnormalities, we treat them, we correct the issues, and the patients can continue with the therapies, and the long-term risk of having issues is lower. So that is just when we are more susceptible. But now we are seeing, for example, patients that had 3 cancers, and we are seeing them in the 4th cancer, and they're planning chemotherapy. So in those patients, we start taking early strategies to prevent all problems at a very early stage, and we are more meticulous to do more screening, to see them more often, to try to identify any subtle change at a very early stage. There's another line. Do statins and amlodipine affect the heartbeats, such as causing premature heartbeats and palpitations? Do these medications have long-term side effects on the heart? Thank you, Fancy, for sharing your question. The answer is no. The statins will prevent having atherosclerosis. They lower your cholesterol. It's a very good medication to protect the heart. We use it in many different conditions, coronary artery disease, for example. And amlodipine is a medication that acts in the calcium channels of the vessels and vasodilate. They open the artery. So it's used for hypertension and even has a very small antiarrhythmic effect. So it can also be used to reduce those palpitations. So in that case, I would say no, the statins and amlodipine will not have any long-term side effect in your heart, and even do probably protect you from different problems. Thank you so much for the question. I'm going to rephrase it. Is if patients had already a heart diagnosed as heart failure when they are diagnosed with cancer, and after that they are referred to our program. So there is a couple of interesting things there. First, when we have somebody with high cardiovascular risk and going to start therapies, we take that approach that I show in the slide. So we're going to be very careful to screen these patients at an early stage, to start planning the therapy, try to choose chemotherapies that have less effects on the heart, try to pick smaller doses of the chemotherapies as well. And also in specific cases as well, for example, if there's hypertension, let's start treating the hypertension, let's control the cholesterol, let's control the glucose, even before we start with the therapies. And that will help a lot to prevent issues. In the other hand, your question is about the fitness. The fitness, we know that somebody with heart disease will have lower fitness if they are not active. And then they receive therapies, the fitness is going to go down. There's few studies that are starting to recommend like intense exercise during the chemotherapy with amazing results. There was published that it's not easy, and that's a challenge because there's fatigue, but doing exercise while receiving chemotherapy will reduce the amount of fatigue, will improve the levels of energy, and will mitigate the reduction of the functional capacity. As I said, this has to be controlled with a good team that is supportive, and understanding that there will be days that the patient cannot exercise, and that's fine, but it's possible. And I think those kind of early interventions, including exercise, not everything is medications, that's what we want to share here, will help to avoid these problems. Yeah, okay, and it's just a follow-up question was if there is any cardioprotective medication to prevent these problems during chemotherapy. So now they have been studied with ACE inhibitors, beta blockers to try to prevent the development of heart injury during chemotherapy. And the answer is no, we don't have strong evidence to use medication to prevent this problem. It has been tried, but the results are not consistent, but I think it has functioned better to do exercise than using medications. So this is great. So I think we are going to close the Q&A for now. If you have any more questions, you have my email, feel free to reach us, our amazing team from the health program. If there's anything, let us know and we'll be happy to get back to you directly.
Thank you very much, Dr. Rivera.